Hello, welcome everyone. Welcome to Agricultural Worker Health 101. This presentation today is presented by the Farmworker Health Network. We have three presenters representing three of these farmworker health organizations. Again, my name is Colleen Reinert. I am a program director with MHP Salud, and I'm going to go ahead and give the opportunity to my co-presenters to present themselves. Robyn, if you want to go ahead and get started.
Hi, everyone. My name is Robyn Barron, and I am a project manager at Health Outreach Partners, and I'm so glad to have you all here to learn more about ag worker health. And I will pass it over to our other presenter, Gladys.
Buenas tardes a todos. Good afternoon, everyone. My name is Gladys Carrillo. I'm the Director of Program Services at the National Center for Farmworker Health. And we're very excited to be able to share information about this vulnerable population with you all today.
Thank you. So at this time, I just need to do a quick check. All I see on my screen is the original housekeeping choose a language. So I believe we need to get Robyn's slides up on the screen. I'd like to, thank you, take a minute to do that. All right, great. Robyn, if you want to go ahead to the next slide. So again, welcome everyone. As I mentioned, this presentation is presented by the Farmworker Health Network. The Farmworker Health Network works cooperatively with HRSA to provide training and technical assistance to over 1,000 community and migrant health centers throughout the United States. So again, today I am representing MHP Salud. We have Robyn with Health Outreach Partners, and we also have Gladys from the National Center for Farmworker Health. Other organizations that make up the Farmworker Health Network include Farmworker Justice, Migrant Clinicians Network, and the National Association of Community Health Centers. Later on in this presentation, we'll have an opportunity to learn about different services that are offered through each of these organizations. All right, Robyn, we'll go ahead to the next slide. So we're going to start off this presentation today setting the foundation, understanding what is ag worker health. We'll learn more about the specific population of ag workers that the health center program serves. Gladys will go over ag worker health needs, risk, challenges, and resilience. And Robyn will wrap up the presentation going over the resources for training and technical assistance through our Farmworker Health Network. So we're going to go ahead and look at a timeline of legislative action that has been related to migrant health. So our first piece of this timeline is the Migrant Health Act that was enacted in 1962. And this provided financial and technical aid to private and nonprofit agencies that provided community health services to migrant farm workers and their families. Okay, I'm just pausing for a second. My screen flipped. I still see the slides, but I've got Catherine up on my screen, so I'm going to go ahead and continue on. In 1975, there was a Public Health Service Act, and this authorized under Section 330 of the Public Health Service Act. In 1983, we had the Migrant Seasonal Agricultural Worker Protection Act. This was basic labor protections for labor contractors. In 1987, there was a Field Sanitation Act, and this established, this was requiring employers to provide potable water, toilet, and hand washing facilities in the fields. In 1992, we had the Worker Protection Standards, and this set some minimum standards for protecting farm workers from pesticide exposures. In 1996, there was a Health Center Consolidation Act. In 2009, we had the Recovery Act, which provided stimulus legislation and provided over $2 billion for the Community Health Center program. In 2010, there was the ACA was enacted, and this included, again, a major expansion for the health center program, dedicating $9.5 billion to serve 20 million new patients. And then in 2014, the ACA was fully implemented. So I want to talk a little bit about farm worker exceptionalism. So while we were able to see certain legislative action that happened through that timeline, Robyn, if you want to go ahead to the next slide, there were some acts that we want to talk a little bit about. Specifically, the Fair Labor Standards Act. This left out farm workers, specifically child labor protection and overtime protection. Farm workers were also excluded from many state minimum wage laws and worker compensation coverage. And few of the ocean standards were set to protect farm workers. So when we looked at the field sanitation standard of 1987 that required potable water, toilets, and hand washing stations, this only applied to farms with 11 workers or more, or that they had housing. So again, there were several areas within the legislative action that left out groups of farm workers throughout. Just quickly, I see, will the presentation be posted for the conference website? Yes, it will be available. All right, thank you. Robyn, so if you can go ahead to the next slide. So really, what is the 330 program? Section 330 of the Public Health Service Act created and authorized the health center program and permits HRSA to make grants to health centers. So when we talk a little bit about health center funding later on in this presentation, it's this act that it has allowed HRSA, the Bureau of Primary Health Care, to provide funding to the health center programs. So to understand a little bit more about public health Section 330 delivery sites. So in 2019, the Bureau of Primary Health Care supported over 1,300 health center grantees, which included homeless, school-based health centers, public housing, and migrant health. So in 2019, 175 of those were funded to provide services to the migratory and seasonal agricultural worker population. 2019 documented 1,031,049 ag workers that were reported to be served by the health center program. Anyone that was on the session this morning, as Jim McCrae mentioned, the goal pushed by National Center for Farm Worker Health and Bobby Ryder to serve over 1 million farm workers. This was a huge accomplishment through the health center program grantees. So while it's an accomplishment, it also allows us to all recognize that there's more we can do and that we are positioned in a place to do so. So what exactly is an ag worker in the Section 330 funding? So it's important to note that every agency has a different definition for agricultural workers. The way the Department of Labor defines an ag worker, Migrant Education, Migrant Head Start, and the Health Center program all defined an ag worker differently. Specifically for 330G funding, a migratory ag worker, their principal employment is in agriculture. They have been employed within the last 24 months, and they establish a temporary home for the purpose of such employment. A seasonal agricultural worker, their principal employment is agriculture on a seasonal basis, and they do not migrate for farm work. And then lastly, there's the aged and disabled agricultural worker. This is an individual who has previously been a migratory agricultural worker, but who no longer meets the requirements because of an age or disability. So more specifically, as we look at the UDS manual and how ag worker is defined in the UDS manual, you'll see that there's different levels. There's crop production, animal production, and aquaculture, as well as support activities for crop production and animal production. Again, an ag worker needs to meet fill in the blanks for these specific services in order to meet the definition of an ag worker served through the health center program. So if we go to the next slide, who does that not include? Or workers that are employed in the following industries and are not eligible for agricultural health program. We're looking at spectator sporting, transportation of livestock, trucking and timber, landscaping, and meat product merchant wholesalers. So historically, it's always been picking and packing has qualified to meet the ag worker definition, or tree planting, but not tree cutting. So there have been some efforts made in cultivation and preparation. However, currently, these industries are not eligible for the agricultural health program. All right, so as we look at the Migrant Health Program grantees and satellite sites, this map shows where there are migrant health grantee programs. However, I want to note that not all points necessarily represent clinics that are serving agricultural workers. So since grantees are identified by the source of 330 funding that they have, such as migrant, homeless, community, and public housing, and their satellite sites, these sites adopt the same classification whether or not those sites serve agricultural workers. So for example, a community and migrant health center in Oklahoma that has about 14 sites but only serve agricultural workers in 2 sites, they will be identified. Similarly, a health center, a migrant health center in Florida that has a total of 43 sites, 9 are health centers, 34 are school-based health centers, but ag workers are only seen in 5 of those site locations. So there is a wide spread of migrant health program grantees. And if you can kind of take a snapshot of this in your mind, when we look at where the majority of the farm agricultural workers are located throughout the United States, it will align with where the migrant health program grantees are located. So what is a required service for a 330 program? All 330 programs must offer primary care services, preventative care services, emergency services, pharmacy, outreach and enabling services, a sliding fee scale, and have patient majority governing board. I mentioned a little bit about the health center funding. So health center budgets range between $500 and $25 million. Obviously, the scope of services and size of the health center will make a difference there. The Bureau provides approximately 28% of the health center's total budget. So for every dollar provided by the Bureau of Primary Health Care, the health center must raise $3 additional. So now that we've talked a little bit about the history of ag worker health and how agricultural workers are defined for the health program, we're going to talk a little bit more about some demographics related to the population of the ag workers. I'm going to ask everyone to take a minute and think in your head, how many ag workers do you think there are in the United States? Gave a little bit of a picture letting you know that we served over 1 million health center or 1 million ag workers in the United States in the 2019 UDS data. But how many ag workers do you think there are in the United States? Gladys posted the question in the chat. Please feel free to answer. All right, we have a range of answers. Thank you for participating. All right, Robyn, if you want to go ahead and move forward. So I'm going to go over some demographic data about the ag worker population in the United States, but I do want to preface this by letting everyone know that it's difficult to collect accurate data on ag workers due to constant mobility, language, cultural barriers, and fear of sharing information due to immigration status. Many of the stats that we are talking about today leave out many more farm workers. However, based on the data that we do have, it does allow us to put things into perspective. So there are approximately 2.5 million agricultural workers in the United States. If we include their family members, it goes up to 4 million. So of these, 68% are considered male and 32% are female. And there's an estimated of 44% that are young, or between the ages of 20 and 35 years old, and actually many are much younger than that. There's an estimated 25,000 children ages 14 to 17 working in agriculture. Though this number is likely an underestimate because the National Agricultural Worker Survey only interviews children between the ages of 14 to 17. However, U.S. labor law allows children as young as 12 years old to work in the fields with parental consent. So in terms of the language spoken, over 70% of ag workers are Spanish speaking, which makes a lot of sense given that the majority, 77%, are categorized as Hispanic or Latino, and 76% are foreign-born, primarily from Mexico. So as you'll see on the slide, while majority do come from Mexico, there has been a recent increase in ag workers immigrating from Central America, from countries like Guatemala, Honduras, El Salvador, and this has largely been attributed to economic hardship and political instability in this region. Now, while 69% of workers come from Mexico, it's important to mention that in recent years, there has been a large increase of Indigenous people immigrating to the United States from Mexico. These individuals speak an Indigenous language and Spanish as a second language. And this is important to keep in mind as we start talking about some of the barriers to care among the ag worker population. So on the next slide, we talked a little bit about foreign born, and you'll see there's an average of an 8th grade education level. 37% have no healthcare visits in the last 2 years, which is partially due to the fact that 53% reported not having any health insurance. So in addition to not having health insurance, ag workers face economic hardship. In 2015, the average ag worker income was $20,000. 33% of ag worker families' total income falls 100% below poverty level. So we've talked about ag workers in general, but in the United States, there is a program, the H2A program, that allows U.S. employers or U.S. agents who meet specific regulatory requirements to bring foreign nationals to the United States to fill temporary agricultural jobs. In 2020, there was 275,430 H2A positions that were certified by the Department of Labor. So employers need to apply to the Department of Labor, and they need to demonstrate that they do not have enough U.S. workers to fill their jobs. There's no cap on the number of H2A visas issued, and employers must be able to provide transportation, housing, worker compensation, and a minimum wage rate. H2A workers also do qualify and are eligible to enroll in health insurance through the ACA. So the H2A workers, and then where we previously mentioned the indigenous agricultural workers. So there are indigenous Mexicans and Central Americans are the fastest growing farm worker population in the United States. They speak different languages, and because of these distinct languages and cultural beliefs create more barriers to healthcare that are more complex than barriers experienced by the non-Indigenous Mexicans. So when we look at the number of where agricultural workers are by state, and we go back to that snapshot that we took of where the migrant health centers are located, it's no surprise that over 1 million of our nation's farm workers are located in California, followed by Texas, Washington, Oregon, and Florida. So we talked initially about the difference between migrant and seasonal workers. So as a reminder, a migrant worker seeks annual employment and will follow a harvest season from region to region. This trek often requires them to relocate several times a year and work with many different crops in different locations. So for example, it could be a farm worker that harvests citrus in Florida during the summer and goes up to North Carolina in the springtime to work with lettuce. A seasonal worker is going to remain in one location and are often employed for a few seasons out of the year, though their responsibilities change throughout the year. So for example, they may be involved in several stages of the production for the same crop. So for those that migrate, they have different patterns of mobility. So the first one noted on this map is the restricted circuit. So many farm workers travel throughout a season within a relatively small geographic area. So for example, on this map, you can see the California Central Valley along the Nebraska Interstate 80, or during chili season, harvesting in Texas in the El Paso and Las Cruces area. There's then point to point, and another group of farm workers will migrate to the same place or a series of places along a fixed route during the course of a season. These people tend to live in a home-based area like Florida, Texas, Mexico, or Puerto Rico, or California. Then lastly, though nomadic, and Robyn, if you want to move the animation on, other farm workers travel away from their homes for long periods of time, sometimes many years, working from farm to farm and crop to crop. Some of these farm workers may eventually settle into an area where they migrated, while others will eventually return to their home base of country. So I'm going to now go ahead and pass this presentation over to Gladys, who will go over agricultural workers' health needs, risks, and challenges.
Thank you, Colleen. So we can go to the next slide so we can begin the conversation about the different needs that agricultural workers have. I would like to ask everyone in the audience if they can share a little bit about what they have seen that impacts agricultural worker health. And we're going to talk a lot more in depth about what the specifics are, but if you have any particular challenges that you noted in your service site or in your particular area, feel free to drop it in the chat now, because you will note that we will probably be talking about it as a risk factor for this vulnerable population. Next slide. So as you think about these different factors that impact agricultural workers, I ask you to really consider the different social determinants of health that affect this vulnerable population. As you can see here by the image depicted on your screen, there's a number of factors that impact agricultural workers at different levels. There's some that are systemic, and there's some that are individual. And I'm seeing several different people note some comments in the chat about what those factors are and what we commonly see amongst this population. Next slide. So some of you have mentioned some of the individual barriers that this population face, as well as systemic factors that impact them. Discrimination is definitely something that this population experiences, and that affects whether or not they access care. So if an agricultural worker is fearful and hesitant to access care because they might be deported, they're less likely to seek services or treatment for any type of health condition that may be affecting them and their families. Immigration status is a big factor that affects agricultural workers' ability to receive care. We also have several other factors that some of you have noted even in the chat, so thank you for that. And they include language, regulatory issues, and all of them definitely impact the continuity of care that agricultural workers may need depending on the type of condition that they may be experiencing. Next slide. We actually have a case study that my colleague Robyn is going to read to get you all to think about some of the different challenges that this population faces, and we'll be asking for your participation as we process the case study further. Robyn?
Thanks, Gladys. All right, everyone. So we are going to pause for a minute and take what we have been learning and put into practice. I'm going to read a case study to you, and I want you all to think about the following questions. And we'll put those questions, I'll put those questions in the chat. But one of the questions are, what social determinants of health are influencing Yesenia's situation? And how would you or your organization, clinic, or community support Yesenia in this situation? Feel free to respond in the chat box, and I'll read a few of your responses after I finish the case study. So Yesenia is a 50-year-old woman living in Yuma, Arizona. She has been an agricultural worker for 30 years and travels to Oregon each season to pick blueberries. Several years ago, Yesenia started experiencing knee pain. She has health insurance through her employer, but there is a copay for specialists, and she has to miss work for the appointments. She went to various specialists, which was expensive and time-consuming. All of the doctors told her different things. One even accused her of making up the injury. In the end, she couldn't obtain a diagnosis that would qualify her for disability benefits, even though crouching down to pick lettuce caused constant pain. Now she has carpal tunnel syndrome in her dominant arm. She crossed the border to see a doctor in Mexico, which was cheaper and also guaranteed that the doctor spoke Spanish. However, her experience with the knee injury, she has decided to not pursue disability benefits. She continues working and makes an informal agreement with her mayordomo so that she doesn't have to do the work that's hardest on her arm. She does still have to use sharp tools though, and she's worried that she'll lose her grip and cut herself. When her arm hurts too much to even hold the tools, she skips work. Not being able to work makes Yesenia depressed. Her coworkers are her friends. She's also worried about her family's finances. Now, going back to the questions that I asked originally, what are the social determinants of health that are influencing Yesenia's situation? And the second question is, how would you or your organization, clinic, or community support Yesenia in this situation? Feel free to respond in the chat. Yes, lack of financial support, language, access to care, health literacy, age. Yes, I think that is also another factor that's affecting her. Communication with her provider, support, social support. I think that's a really great one. Transportation. Those are all really great answers. And thank you all for your responses. Fear of losing employment. Yes, that's also a really great one. I'm going to pass it over to Gladys, but feel free to continue answering, especially how your organization can support Yesenia in this situation.
Thank you, Robyn. We are getting a lot of great responses coming through to the chat, so we appreciate you sharing your experiences. The case study depicts a lot of challenges and work-related health risks that a number of agricultural workers experience, like Yesenia. If you recall from what Robyn read, there was some injuries that she experienced as a result of working in agriculture, and that were now really impacting her physical health. So just given the nature of agricultural work, these agricultural workers often experience a number of these health risks that you see on screen, just due to repeated movements, equipment they handle, and environmental factors like the heat that was mentioned. So if you see here, there's a number of musculoskeletal injuries, heat stress, lacerations from equipment or tools. There's also different types of slips, falls that occur, eye injuries, and in particular, we see insect or rodent bites just from farm workers being out in the field as they harvest crops. So this is often seen and experienced by them just due to the nature of the work that they do. Next slide. So this graph here really represents the number of work-related injuries sustained by the agricultural industry in 2019. If you'll see from the graph, it's the third most dangerous occupation following construction and transportation. Next slide. According to the Bureau of Labor Statistics, in 2019, 573 agricultural workers were reported dead due to work-related injuries. Now, we are still unsure of how accurate this number is. As Colleen mentioned, a large number of agricultural workers are underreported. And although there is the national survey that is conducted yearly, we still believe that there is a number of agricultural workers that are not accounted for, much less that also are not included in this number when they experience injuries or fatalities, unfortunately. So how many of y'all think that this is related to the work that they do and also the pesticide exposure that they experience, again, due to the nature of the work? Pesticide exposure is a risk both in the field and at home. Drift is actually the #1 source of pesticide exposure. And unfortunately, it not only directly impacts the agricultural worker that does the work in the field, because that's where the pesticide is typically sprayed on the crop. So it doesn't just impact them as they're gathering and harvesting the produce, but it also impacts their families as they take home the exposure in their clothing, in shoes, or even in their vehicles. The EPA estimates that 10 to 20,000 agricultural workers per year are poisoned on the job due to pesticide exposure. But again, this is probably a big underestimate because pesticide poisoning is largely underreported. A big reason as to why agricultural workers may not be reporting pesticide poisoning is just simply due to the lack of access to health care. Pesticide poisoning also can mimic other illnesses and is very similar to flu or food poisoning. So sometimes pesticide exposure is often misdiagnosed by providers when agricultural workers seek treatment. Next slide. So all of these health issues are things that this population faces, and it's not necessarily different than what the general population experiences in terms of ailments or illnesses, but agricultural workers do have magnified and compounded challenges and barriers just due to the lifestyle and living conditions that this population has. I saw a question just come through to the chat asking if there has been a link between pesticides and other diseases such as cancer. I am not aware of any direct links. I'm sure there are some correlations between the two illnesses, but again, because of the limited data and research conducted on this vulnerable population, it's very hard to have actual factual research available that gives any information about the correlation between those two diseases. But it's definitely something that we can look into, and we can try to gather some additional information for you so that we follow up on that question. Thank you. Next slide. So as I mentioned, some of the common chronic conditions that agricultural workers face is very similar to the general population and is included here on the slide. Unfortunately, though, agricultural workers do experience higher rates of diabetes, hypertension, cancer, and these are probably due to, again, lack of access and then also challenges with outreach efforts and medical interventions. As we mentioned before, a big portion of the population is also very mobile. And so it's hard to provide chronic care management when a patient is constantly moving from one location to another and doesn't have one patient medical home. And so it is very difficult to treat these conditions considering the nature of the work that they do, because there's very limited programs available for agricultural workers to have services as they travel and do work in different regions of the country. Next slide. And now with the national pandemic, we have seen agricultural workers be particularly impacted because they were classified as essential workers. So as they were continuing to pick crops and feed our nation, they have definitely been at greater risk of contracting COVID-19. And there's also a number of other factors that have increased the risk. And a few of you had mentioned them in the question earlier and put them in the chat. So as you see here from the information provided, agricultural workers may not necessarily be tested or receiving COVID vaccines. I think that's definitely something that migrant health programs across the country are currently advocating for, so that agricultural workers can be included in the vaccine rollout and be eligible to receive the vaccine as soon as possible. But until then, there's a number of other challenges that they're experiencing in the field and while doing the work. There's limited access to hand washing stations or access to clean water and soap. Another comment that was provided earlier was the issue of overcrowding, with a lot of people having shared housing or living with close family and friends. It's very difficult to practice social distancing with that because of the limited housing options that agricultural workers have. Transportation is another factor. If agricultural workers are being transported to and from the fields, Again, it's very difficult to have that proper distance and for proper sanitation routines to be implemented in those cases. Some of the other challenges really related to the pandemic that has truly been exacerbated is the fear of accessing healthcare just because of employer retaliation. Agricultural workers may not necessarily receive the same benefits that we do, and they may not be able to take sick time in order to receive treatment or go to an appointment, much less get tested or receive a vaccination. So it's definitely putting them at a higher risk. They also don't have the ability to isolate if they do get COVID-19, again, because of the limited housing options available, or they just do not have the ability to separate themselves from family members or other farm workers. So the risk continues, and there's a lot more cases of agricultural workers obtaining COVID-19. Next slide. Oh, and I'm glad to see somebody mentioned in the chat that farm workers in their state are receiving COVID vaccines now. Great. Do you mind sharing what state that is? Because the last we had heard, Oregon was the only state that had the ability to include anyone they wanted. But we would be glad to hear that other states are jumping on board so that agricultural workers can have access to the vaccine. Oh, Delaware. And it looks like Idaho may be following soon. So let's hope that all states really do start to include this vulnerable population as a priority population so that everyone can have access to the vaccine. Thank you. Mental health is another area that does impact agricultural workers, and that truly it is a part of holistic health when treating patients overall. However, as with just any mental illness, there's still significant stigma that impacts access to care, and this population is not an exception to that. Mental health is not something that is often treated amongst agricultural workers, and unfortunately, within the Latino Hispanic community, mental health services is often very taboo and not necessarily well received with the population. So agricultural workers do experience a number of mental health conditions like anxiety, depression, substance use, and then have other issues that affect their well-being like family violence and stress. So unfortunately, like I mentioned, they don't all access care or have the ability to seek services for a number of reasons. Excuse me. Agricultural workers also resort to a number of homeopathic remedies and cultural practices. So again, because of the population and where they come from, some agricultural workers might do some other type of ritual or engage in some sort of herbal tea or practices like that that are specific to the culture. And Western medicine and therapy services might not necessarily be the first option for agricultural workers. So as providers within this population, it's very important to be aware of different practices like or even terminology that agricultural workers may use to refer to mental health conditions like nervios or susto, which are common terms within the Latino Hispanic community. Next slide. A number of the contributing factors to mental health challenges are listed here, and I think a lot of you are very familiar with them, just given the responses that you have entered in the chat. The agricultural worker families often experience isolation because they're separated from their families. And so that does contribute very heavily to any mental health symptoms and conditions that they might experience. Trauma, as well as discrimination, are other big factors. Again, it just depends on the ag worker's experience in coming into this country, how they got here, any type of trauma that they might experience in their journey, and then experiences that they might have when they're in this country doing the agricultural work. And then COVID-19, I think that's added a challenge to everyone's mental health in the United States, including agricultural workers, just given some of the barriers that they already face. Next slide. Some other illnesses that are also associated with different conditions that farm workers experience are here. Gastrointestinal diseases, infectious diseases, intestinal parasites, conjunctivitis, and lead poisoning are some of the few that we've seen just in terms of the housing and living conditions that agricultural workers are in. As I mentioned earlier, some of them may share housing with family or friends. Others may live in labor camps or housing provided by the contractor. However, we commonly see that these properties are not very well maintained, or again, are kind of substandard. And so agricultural workers do experience significant risk related to housing in terms of their health. Next slide. So one of the questions that we wanted to pose to the audience is really asking about what are the barriers to care and healthy lifestyles for agricultural workers that you commonly see in your area. And I think several of you have mentioned some that you know that are just barriers overall, but particular to your sites. With the populations that you work with, is there anything that truly stands out to you that you have noted as a significant barrier to workers at your health center? It would be great if you shared that with us in the chat now, so that we also can start to note any particular factors that really contribute or challenge this population and help us really figure out how can we address it so that it's not something that deters them from accessing quality health care. And I'll read some of the responses that come through. It sounds like maybe having some culturally competent providers, clinic hours that are available, especially if an agricultural worker works during the day. They may need evening or even weekend hours, and child care might be another barrier to consider. Substandard housing, immigration status, language, lack of information in the patient's native language, access to dental health issues, food deserts. That's definitely something that we often see in rural areas. Fear to receive any health services due to public charge concerns. Now, that was something that we recently experienced for sure. Thank you, everyone, for entering some of that information into the chat. We're going to be talking about all of those as we have some already. But in the next slide, we've listed a number of the items that you all have highlighted. And this list, unfortunately, is not exhaustive. There's others that you have already entered into the chat and that we haven't even included here on this slide, but that definitely are barriers to care for this vulnerable population. But some of the ones that we have noted in particular are language and cultural factors. We often see, as Colleen mentioned, that most agricultural workers do not speak English. Most of them speak Spanish, but we've also seen now more recently other Indigenous language and even Haitian populations who speak Creole. And so there is a need for patient health information in other languages besides English, and that is very low literacy and easy to read for this population. So, this feedback and information truly helps us be able, as national training organizations, develop valuable products and tools that are helpful to you as healthcare providers. It helps us to see what the needs are of your patient population so that we can tailor and really be responsive to your needs and develop patient education materials so that, language and culture doesn't necessarily have to be an added barrier to care. However, obtaining culturally competent providers still is something that we need to work on as a public health community so that agricultural workers can have access to care with the providers that they feel comfortable with, that they can actually communicate with in their native language, and not be fearful of asking questions or just of trying to understand the healthcare system, which is an added barrier in itself. Next slide. So as a result of all the challenges that we've all already noted and briefly talked about, we have considered some ways that maybe service delivery needs to be adjusted. And as you see here from the slide, you all mentioned some of these challenges and reasons why we need to make adaptations so that agricultural workers can receive the care that they need. Some of the information listed here is just really to improve the communication between providers and to have information available to patients so that they better understand the health system and also the health conditions and treatments available for them. Next slide. We also want to note some challenges within operations and costs overall. As Colleen mentioned earlier, the majority of families that are agricultural workers have incomes below federal poverty level. And so when there is a lack of insurance or costs that are not covered with services, it is a huge barrier to these families in receiving treatment. And not only that, the hours, the transportation, like we mentioned, and then just having the accessibility to care without that necessarily being a choice between working and providing for their families and then, having to receive treatment, which is sometimes often a choice that a lot of agricultural worker families need to make. Next slide. So these are a few adaptations that we have highlighted for health providers so that, you consider as you work with this vulnerable population, what are some changes that you could do to your operations, to your service delivery, so that you are able to reach this vulnerable population. And the next slide are some recommendations that we've provided that you hopefully can take back to your health centers on ways to make some of these adaptations to service delivery so that the barriers are maybe a little less of a challenge for families as they try to take care of themselves and their loved ones. Some of the adaptations, like we've mentioned, is truly looking at information that is provided to the patient and ensuring that it is culturally relevant and in a language that is appropriate, as well as in a level of literacy that is easy to understand. In terms of mobility, we encourage, if possible, to utilize portable medical records. I know a number of different health centers that also have mobile units, and so they can provide services actually in the field, and without that worker necessarily losing a full day's wages. Other services that we really encourage people to utilize is the use of promotores de salud or community health workers to conduct a lot of the outreach. And so patients are better informed and aware of the services that they have available to them. If that's not an option, really coordinating with community partners like schools, growers and farmers in your area. So those relationships are established and you can bridge or be a bridge to help ag workers be able to have care, even if they may not necessarily be able to go to a health center themselves. Next slide. A few other recommendations that we offer is truly to try to orient all patients to the healthcare system at your health center. And in large part, that is related to what community health workers do in the field as they provide information to patients about your health centers. So having them help patients understand how the healthcare system works, what to expect from an appointment, maybe even helping them get registered so that agricultural workers can have easier access to healthcare and can make their appointments. We also encourage everyone to document the number of agricultural workers in your area and typically what a season would look like so that you as a health center can make some of those changes to your hours, maybe even changes to the type of transportation that you have available so that it's a little easier for, again, ag workers to be able to receive services without necessarily disrupting their work schedule as much as if they needed to take a full day off. And as I mentioned, just accommodating for their season. So as Colleen mentioned, there's migratory workers that truly travel and can be at different locations. And then there's more seasonal workers that don't necessarily have to establish a temporary home, but they're the tasks and kind of things that they do throughout the year for a crop may change. And so really becoming familiar with your patient population is critical in being able to make some of the changes to your services. Next slide. Oh, and I see a question that I could address really quickly before I talk briefly about the voucher program model. The question was, how do you become a certified community health worker? There's different programs that you can attend that provide training for promotores de salud. It truly does depend on the state. And I see my colleague Hansel joining us, who represents one of the FHN members. MHP Salud is one of our partner organizations that actually offer specific training for community health workers. So I would encourage everyone to look up their information and website. And there's definitely ways to get training and certification to become a health worker or outreach worker in your community. So when there isn't a migrant health program available within a community, we encourage health centers to look at a voucher program model because that is kind of the next best option if you're not able to offer a specific, if you're not able to become a migrant health center specific site. It truly does tailor to the season of your agricultural worker and helps you collaborate with the community partners. So through vouchers so that agricultural workers can obtain services, even if it's not necessarily through a migrant health program. There's also the voucher program model really incorporates outreach. That is a critical piece to access to care for this population. So voucher programs really rely heavily on community health workers to be able to inform patients about their vouchers and the different services that they have available within the community organizations that offer those services and collaborate with the health center. Currently, there are about 17 voucher programs across the country. And we at NCFH actually have a learning collaborative that is specific to the voucher programs. So if it's something that you're interested in, I would encourage you to reach out to us and let us know, and we'd be happy to help you. I'm going to go ahead and now pass it on to my colleague, Robyn. Oh, not quite yet. I forgot there was actually one more slide. I apologize. One other resource that I wanted to highlight is from another one of our FHN partners, MCN, the Migrant Clinician Network. This is definitely a very beneficial program that I think is a solution to some of the challenges that we've identified today. Is the Bridge Case Management Program. And in a nutshell, it's a program that MCN offers to really ease the continuity of care so that agricultural workers receive services no matter where they are. So the Bridge Case Management Program really facilitates open communication between providers, and it actually allows for the store and transfer of medical records across state lines and in different places of the country. It's a toll-free program that patients can access and they can get enrolled for. Enrollment's very easy and it's available in multiple languages. And like you see here in the slide, it's really available in different parts of the world, again, to facilitate that healthcare no matter where the patient is when they are completed with their season or agricultural work. So it's something that I would encourage everyone to look into if it's a program that you think your patients could benefit from and that they can enroll in so that they have continued care regardless of where they're located. Thank you.
Thank you, Gladys. And we are wrapping up, and we just wanted to end with sharing some resources for you all so that as you are navigating, learning more about ag worker health, that these are some resources that you can really dive into and just be able to expand your knowledge. So if you're wanting to find out where the closest health center is to you, you can either go directly to the websites listed here and look at their directories, or you can call the free clinics directory, whose number is also located here, and you will have these slides available to you after this presentation. You can also learn more about ag worker health through NCFH, who have an ag worker access campaign that they're doing. If you're wanting some help in training and technical assistance, you can reach out to any of these national training and technical assistance partners who are all funded through HRSA. Now, some of the NTAPs that I want to highlight are Farmworker Justice. Farmworker Justice is a nonprofit organization that seeks to empower migrant and seasonal farm workers to improve their living and working conditions, immigration status, health, occupational safety, and access to justice. They are advocacy and policy focused. Farmworker Justice, since its inception in 1981, has filed lawsuits on behalf of farm workers and their organizations, often in collaboration with other advocates and attorneys to maximize their impact. They've introduced bills to Congress and impacted things at a policy level. For those of you who may not be familiar with my organization, Health Outreach Partners, or HOP, HOP is a national nonprofit organization based in Oakland, California. We like to refer to ourselves as advocates of outreach because we see its importance in connecting to vulnerable and underserved communities, building relationships, and facilitating access to care. So our mission is to build strong and effective and sustainable health outreach models. We do this through trainings, consultations, and providing key outreach resources. We work primarily with health centers, PCAs, and other safety net organizations. MHP, Salud, as an organization, they value community-driven approaches based on collaboration, empowerment, and proactive problem solving to eliminate the root causes of health inequity. They bring their strong training for community health workers and promoter staff training models. They have a strong commitment to community-driven approaches. The Migrant Clinician Network is a nonprofit organization that provides support, technical assistance, and professional development to clinicians in community health centers and other healthcare delivery sites. They are the clinical side of the Farmworker Health Network. They have a lot of people with clinical experience on their staff, and this would be a really good place to find COVID resources for health centers. The National Association of Community Health Centers brings in a wealth of knowledge surrounding community health centers, as well as partnerships. And we also have the National Center for Farmworker Health, which is a nonprofit organization whose mission is to improve the health of farmworker families and having access to quality healthcare. They provide information services, training, and technical assistance, and a variety of resources and tools to community and migrant health centers nationwide, as well as other organizations involved in farm worker health. They recently celebrated their 45th anniversary last year and pride themselves in continuing to raise awareness for agricultural workers and their families through the Ag Worker Access campaign, which we showed earlier. Here are some resources for other national conferences that you can attend to learn more about ag worker health. Health Resources and Services Administration, or HRSA, has a website that has a ton of information that you can learn about ag worker health. And here are some other NTAPs that have a special focus on special and vulnerable populations, as well as other organizations that have a focus in capacity building and development. And you can also find out more information regarding ag worker health through the Resource Clearinghouse. And you can get information, articles, and just really gather more stuff that can help gain more information for your health center. And with that, we really want to thank you all for participating in this presentation. And if you have any questions, please feel free to enter them in the chat. And I see here that Catherine put in the chat to fill out the evaluation for this session before you go. And I will pass it on to Catherine to explain a little bit more about the evaluation for the end of this webinar. Thank you so much.